Welcome back. We're going to be talking now about pressure changes and resistance. So we're going to talk more specifically about the changes in pressure that occur when we're going to breathe. And then we're also going to factor in resistance of the airways and how that's going to affect the amount of air that we get into our lungs. So to start off, we need to go back to the anatomy of the respiratory system again, where we said that we're going to have our lungs in the chest cavity. And we've been talking about how if the chest wall expands, the lungs are going to expand as well. And so this is the explanation for that, and it's because we have the pleural sac, where the inner layer of the pleural sac is attached to the lung. So that's right here. And then the outer layer is attached to the chest wall. And in between, we have fluid, so that whatever happens to the chest wall, the lungs are going to follow. You can think of this like an example if you have two glass slides or two glass plates, and you know if you put water in between them, you're going to be able to slide them along each other very easily, but to pry them apart gets really difficult, again, because of the surface tension of water. And so that's how this fluid in the pleural sac functions, to allow for there to be no friction between the lungs and the chest wall, but yet to keep the lungs next to the chest wall. So that's the function of the pleural sac. So now that we've talked about that, we can consider the pressure in the pleural sac. So we've got a few things marked here where we've got the pressure, atmospheric pressure, which we're going to just assume is zero. We know it's really equal to 760 millimeters of mercury, but for ease of computations, we're going to just call it 0 millimeters of mercury. And we've already talked about the pressure in the alveoli, which is going to be P capital A, P big A. So we're just kind of considering the pressure in the lungs in general in this diagram. And then we've got the chest wall and the intrapleural fluid. That's that fluid in the pleural sac between the lungs and the chest wall, which we're going to call PIP. Remember, even at rest, we've got two opposing forces. We know we've got the recoil of the lung. That's what's represented right here. And then the chest wall also has its own recoil, so that it wants to expand. So that means that on this pleural space, we have two opposing forces that in this diagram both have a pressure of 0, and so that's going to mean that the intrapleural pressure is going to be negative in this situation, because it's got two forces pulling on it in opposite directions. So that we can say that the difference in the alveolar pressure and the intrapleural pressure is going to be what determines lung volume, and we'll see that in just a minute. The important thing, too, is that for the lung to stay open, the intrapleural pressure needs to be less than the alveolar pressure. It could be, even if it becomes equal, you're going to have an issue, and this is what happens in a pneumothorax when for instance, if you get stabbed or somehow poked so that you allow air to enter that pleural sac, which then makes this intrapleural pressure equal to 0, which means that it's equal to alveolar pressure. And so that's called a pneumothorax. You've got air in that pleural sac, and then that's what causes the lung to collapse, when the intrapleural pressure equals the alveolar pressure. And so not only will the lung collapse, but then the chest wall will also expand, because you've also removed it from being held into the pleural sac. So you'll have both a lung collapse and the chest wall expand if you make this pressure equal to alveolar pressure. So let's talk about then what's going to happen through the ventilation cycle. We're going to start at the end of expiration, where we've just exhaled. And so now we've got the scenario that we just talked about, where the chest wall wants to expand, the lung wants to contract, and so we've got a normal intrapleural pressure of -3. As we inspire, just when we're starting to inspire, we're going to increase the force that the chest wall is exerting on the system. It's expanding, and that's going to stretch the lung, so it's going to have greater recoil, and so that the intrapleural pressure will now be even more negative. Since it's more negative, and we said that the difference between the alveolar pressure and the intrapleural pressure is going to be determine the lung size, then that's going to cause the lung to expand. As the lung expands, it's going to be a greater volume with the same amount of air, and so according to Boyle's law, that means now we're going to have a negative pressure in the alveoli. The intrapleural pressure is still more negative, but now we have a negative pressure in the alveoli, which means we're going to have airflow in, because the difference in the alveolar pressure and the atmospheric pressure determines airflow. In this next step, at the end of expiration, now we have made the chest wall even greater, so our intrapleural pressure is even more negative. Our recoil of our lungs is even greater because it's larger, and so now we've had our increase even more in the volume of the lung. And at the end of expiration, after just a split second, then we will have equilibrated between the alveolar pressure and the atmospheric pressure. So in between breaths, the pressure will equilibrate between the alveoli and the atmospheric pressure. Then we're going to start to expire, to exhale. We're going to relax the diaphragm. So that means that our force that the chest wall is producing to expand has now greatly reduced. And so our intrapleural pressure is going to be less negative. Our alveolar our lung is going to be smaller now. And since we've got the same amount of air in a smaller space, the pressure has increased in the alveoli, which means air is going to flow out. That's going to continue to happen till we get to the end of expiration, where now we're back to where we started from. Our intrapleural pressure is negative, but not that negative, so our lungs size is not that large, and we've had time for equilibration so that our alveolar pressure is 0. This is what I call the plastic lung, and it's going to demonstrate a lot of the principles that we've been talking about in terms of the pressures that are occurring and changing during breathing. So the black balloon is going to represent the lung, and then the air in the canister is going to represent the intrapleural space. And then if I pull on this latex at the bottom, then I'm going to make the volume inside the canister larger, which is going to decrease the pressure in the intrapleural space, which is going to occur during inhalation, and it's going to expand the lungs. So as I make the air chamber larger, which means the pressure is going to go down, then the lung is going to follow. That's what we talked about, of the difference between the pressure inside the alveoli versus the intrapleural pressure is going to determine the size of the lung, and that's what's happening here. Decrease the intrapleural pressure, the lung is going to expand. Increase it by making the chamber smaller, and the lung contracts. Then remember, we also talked about how it's important that the intrapleural pressure always be less than the pressure in the lung, that if not, you're going to have the lung collapse, which is a pneumothorax, which happens to people if they have fluid or air enter the intrapleural space. And so when I remove the stopper, which is going to let the chamber equalize with the atmospheric pressure, which is the same pressure inside the balloon, you'll see how the balloon collapses. And we've now have a collapsed lung. So now we're going to consider resistance in the airways, what influences resistance, and then how that's going to affect airflow. So again, we're going to have the same equation that we use in the cardiovascular system, where the difference in the alveolar pressure and the atmospheric pressure is going to what determines flow, and that we're going to have a large contribution from resistance. So we know that one of the most important things in resistance of these tubes is going to be the diameter. The smaller the diameter, the greater the resistance in the tube, and so flow will decrease. In the lung, the farther you go into the lung, the more tubes you have, the more cross-sectional area you have, so the resistance is going to get lower as you enter the lung. And then we've also talked a little bit about how lung volume is going to affect the diameter of the airways, so that when your lung is full, everything's stretched, and so the airways are not as compressed, and so resistance is going to be decreased. And this can actually be used as a compensation for a lung disease. So if it's hard to exhale, as in an obstructive lung disease, then you can kind of breathe sometimes at a greater lung capacity, so that your lungs are more inflated even when you're exhaling. It can be a compensation for certain lung diseases. As with the circulatory system, we're going to be able to control the diameter, particularly of bronchioles with all that smooth muscle, to be able to control flow. And this is going to be in contrast to the circulatory system, where sympathetic stimulation is going to cause relaxation in the bronchioles. This makes sense. If you're doing flight or fright, you're going to want to be able to open up your airway so that you can get air into the lungs, and so you're going to want relaxation, in contrast to when you have parasympathetic stimulation, you can have that smooth muscle constricted and contracted. And then we've talked about this a little bit, but we're going to talk about a little bit more where the elastic recoil of the airways is going to be important. So in diseases such as emphysema, where we have the reduced elastic tissue, which means we have increased compliance but decreased recoil, that can affect, since you've got less recoil by the lung, that means that the intrapleural pressure is going to be less negative. You've got less of one of those forces that is making it negative. And so the airway diameter can be smaller and the resistance can be higher. So if you don't have that recoil, then that can affect the airways, and that's what we're going to be talking about right now. This is going to be particularly prominent when you're really trying to force the air out quickly. So for instance, if you're trying to exercise so that you can get the air out quickly and then quickly inhale, and so you want to do a forced exhalation, force the air out quickly. In a normal person, that will be that the intrapleural pressure can become positive because you're really squeezing that pleural sac. However, it's still less than the alveolar pressure, so we're not going to collapse the lung. We've got that good lung recoil, so we're the lung is going to really contract or get smaller, which is going to make that pressure increase. And then as it moves out of the respiratory system, the pressure will drop because of the resistance of the tubes. The thing that would be worrisome is you want to make sure that the pressure in these tubes is at least equal or less, or greater, than the intrapleural pressure. Otherwise, it will collapse. And so here, when the pressure finally does get below the intrapleural pressure, it's okay because it's in a structure like a bronchus or the trachea where there's cartilage, so it's not going to collapse. This is in contrast to an obstructive lung disease like emphysema, where we've lost some of our recoil, so that even though we have a high intrapleural pressure, because the lung is recoiling less and it's getting smaller less efficiently, we've produced a smaller alveolar pressure. It's closer to the intrapleural pressure. And then we often are going to also have an increased resistance in the airways, so that we can also have a more rapid drop in pressure. And so in this case, what we're seeing is we have this spot right here where we've got a intrapleural pressure, a pressure inside the airway that's less than the intrapleural pressure. And it happens to be in a portion of the system that doesn't have cartilage. And so what that means is we're going to have compression at that spot, if not collapse. And so we'll get this state where we'll have dynamic compression, where the pressure will build up and open it, but then it'll fall again, and we'll have this dynamic process of it opening and closing because of all of these factors of less recoil in the lung and higher resistance in the airways that makes the pressure drop more quickly into areas where there isn't cartilage. So we've talked about the differences in pressure that are going to determine airflow and lung size, and then we've talked about how airway resistance is going to increase even in a normal person during expiration. But during forced expiration, if your intrapleural pressures are going to become positive, small airways can become compressed, especially in diseased states, and then they could even collapse.